Yes.
Thank you very much.
Shuman, you start.
Shuman, you start.
So thank you. Thank you all the participants. As you know, this is our last program on stomach malignancy. After this, this today's session, we will start colorectal episodes. So this is the last discussion on stomach cancer. I would like to request all of you today's presentation. Today we will discuss a very interesting and very novel approach that is not very common here in Bangladesh. That is the HIPAC, PIPAC, this sorts of management that is not very common here in Bangladesh. But we definitely we have heard a lot about these things. So let's see what actually we have missed so far. So is there really a good options there that is left here in Bangladesh? So today's speaker, none other than Dr. Hasan Shahriar Kallol, a very promising face in surgical oncology. He is a professor right now working in the National Cancer Institute in Surgical Oncology Department. And today, our overseas faculties, Dr. Betnarski, is the assistant professor and senior consultant surgical oncology, mainly focused in colorectal surgeon. So she is right now working in National Institute Hospital, Singapore. So without any delay, I would like to request to this presenter, Dr. Shahriar Kallol, to present his discussion. So Dr. Shahriar Kallol, over to you.
Thank you very much. I'm sharing the screen right now. Can you see?
Yes, can.
Okay, thank you. So good evening, good afternoon to you all. Today I'll talk about the emerging novel approaches for advanced gastric cancers like CRS, HIPAC, IP chemo, PIPAC, etc. So I'm Dr. Hasan Shahriar Kallol, working in the Department of Surgical Oncology. So peritoneal mets from gastric cancer, what actually we do know? 40 to 60% of patients with metastatic gastric cancer develop peritoneal mets, either synchronous or metachronous. So patients with peritoneal mets have a poor prognosis that we all know. Systemic chemotherapy, so far the standard treatment for metastatic gastric cancer, it prolongs overall survival in a smaller way. Better results found in Asian patients, and they are more likely to receive second and third line therapy. But systemic chemotherapy has poorer efficacy in patients with peritoneal mets. What is the expected overall survival in patients with peritoneal mets from gastric cancer? 4 months? Let's check. So here I've shown French registry and Dutch registry. And according to the French registry, the patients with peritoneal carcinomatosis from gastric carcinoma, the median survival is only 3.1 months. In Dutch registry, the patients with peritoneal mets, they have shown that among 2029 metastatic gastric cancer, 491 patients had peritoneal mets, and the median overall survival was 4.6 months only. So from 1995 to 2012, we see that the percent of the patient receiving chemotherapy for metastatic gastric cancer in Dutch registry increased a lot, from 11% to 43%. And the median overall survival also increased quite 5.7 months to 7.9 months, but not that much. So why do patients with peritoneal carcinomatosis have poorer survival? No difference in performance status or number of chemotherapy cycles received, and peritoneal carcinomatosis does not respond well to systemic chemo as liver or lung disease. Anatomical location of the peritoneal disease also makes progression, result in dysfunction. So what are the treatment options for established peritoneal mets? Systemic chemotherapy, I have told earlier that this is so far the standard of treatment. Only a small fraction of systemic therapy enters a peritoneal cavity truly. So what are the other options? It may be IP chemotherapy. Intraperitoneal therapy generates higher locoregional dose intensity in the peritoneal cavity. IP drugs with higher molecular weight like taxanes stay longer in the peritoneal cavity, and it can be combined with systemic therapy. Regarding HIPAC, there is hyperthermic intraperitoneal chemotherapy. Hyperthermia enhances the cytotoxicity of anti-cancer drugs for cancer cells. And when HIPAC is combined with cytoreductive surgery, the efficacy increases a lot. And PIPAC, it is aerosolized chemotherapy. It has got more uniform distribution and deeper penetration. And PIPAC can be combined with systemic therapy, or it may be called as bidirectional. So the systemic therapy, that is the standard, so far the standard. And all the overall surveillance, you see, there are many trials and all the overall surveillance near about 10.6, 9.5, and so on. So the subgroup univariate analysis of overall survival in Rainbow and Regard showed comparable benefit for patients with or without peritoneal mets. IP chemotherapy in peritoneal mets for gastric cancer, the Phoenix GC trial. So here we see that the median survival with systemic therapy was 15.2 months, and with IP and IV chemopaclitaxel, it is 17.7 months. The 3-year overall survival was 6%, and with IP-IV chemo, it was 21.9%. Now, CRS HIPAC, cytoreductive surgery combined with hyperthermic intraperitoneal chemotherapy. The history of CRS HIPAC, as it is very new to our faculties and students here in Bangladesh, so I'll talk about a bit more for CRS HIPAC. So in 1930s, JV mix started aggressive debulking in patients with ovarian cancer with peritoneal mets that demonstrated improved survival. IP chemotherapy reported in 1978 by Dedrick et al. HIPAC was first described by Spratt in 1980 for pseudomyxoma peritoneal actually. Sugar-Baker proposed 6 specific peritonectomy procedures for complete cytoreduction. And then Koga et al., Toi et al., and Fujimoto et al. Expanded the investigations towards its use in metastatic gastric cancer. So what is the rationale of using cytoreductive surgery and HIPAC? Essential that the surgery resects all macroscopic disease greater than 1 millimeter. That is very important. Chemotherapy cannot penetrate more than 1 to 2 millimeter in depth, but hyperthermia potentiates the penetration and activity of the chemotherapy. HIPAC is performed immediately after surgery. The worldwide situation, not many centers are doing this surgery. In USA, the number of centers performing the procedure has doubled in the last 5 years, but in 2009, it was like 52, and in 2013, it is near about 100 plus. So 1,300 to 1,500 cases done annually. In Europe, there is 109 centers. In Germany, 35, France, 30, Spain, 16, UK, Switzerland, Italy. In Asia, Japan, China, Singapore, India, Thailand, South Korea, Philippines, and Taiwan is doing this procedure so far. So what is the cytoreductive surgery and HIPAC procedure? This is Professor Paul Sugar-Baker. He is the Director, Center for Surgical Oncology, Washington Cancer Center, Cancer Institute, and he is called the father of CRS HIPAC because he has done so many studies and trials for this. So removal of all the macroscopic peritoneal disease is the very first and foremost step of cytoreductive surgery. Then resection of involved visceral organs, then removal of sections of involved peritoneum, followed by HIPAC, and finally the bowel anastomosis. So these are the all surgical procedures. I will not go through all these details, but one thing is that peritoneectomy locations, these are very important. Where we resect the peritoneum, the right diaphragmatic copula, left diaphragmatic copula, greater omentum, lesser omentum, omental bursa, right paracolic gutta, left paracolic gutta, Douglas pouch, anterior wall peritoneum, posterior peritoneum, Gleason's capsule, mesenteric peritoneum, and all these. So we do the cytoreductive surgery in a chronological fashion, and involved portions are resected accordingly. So these are some graphical presentation how it is done, the retractors, and you see the involved part of the mesentery, and then sequentially it is removed. Here we see how the peritonectomies are done. So hyperthermic intraperitoneal chemotherapy, or HIPAC, it is highly concentrated heated chemotherapy treatment delivered directly to the abdomen during surgery. So there are some inflow probe and outflow probe, and there are some thermal probe which maintains the temperature inside the abdominal cavity. And this is the machine through which the chemotherapy is delivered into the abdominal cavity. The chemotherapy agent diluted in 2 to 3 liters of peritoneal dialysis solution at 42 degrees Celsius, then temperature probes attached to the inflow and outflow catheters, so that the temperature inside the abdominal cavity doesn't get higher than it is endured by the peritoneum and the viscera. So the advantage of HIPAC, it targets the microscopic disease working on lesions less than 2.5 millimeter. A higher dose of chemo can be delivered with less systemic toxicity. This is very important. And high temperature increases the drug penetration, synergistic effect with intraperitoneal chemotherapy. So quality of life. The quality of life decreases just immediately after surgery, definitely, but it back to baseline by 6 months to 1 year. Comparisons with patients undergoing chemotherapy proves its advantage. Prospective colorectal QL study was done, and it showed that the same return to baseline of the scores, increase in emotional social functioning scores at 6 to 12 months. Factors associated with a poorer QL, higher PCI score, longer duration of surgery, presence of a stoma, and recurrence within 3 months. Patient selection is very important. All the patient going for CRS HIPAC should be discussed at multidisciplinary tumor boards, absence of extra-abdominal metastatic disease, and the patient should be fit for surgery. The PCI, or peritoneal carcinomatous index, should be kept in mind. The completeness of cytoreduction, the CC score, and peritoneal surface disease severity score. So how do we calculate the PCI score? The whole of the abdomen is divided into 13 regions. And the lesion size of the largest size nodule are scored 0 through 3 in each abdominopelvic region. They can be summated as a numerical score, which ranges from 1 to 39. So here, this is the form. And in this form, we actually write that the central right upper epigastrium, according to the lesion size, that the score is 0, 1, also, so 2 or 3. Then we calculate or do the summation of all the numbers, and then we calculate the PCI score. And the CC, or cytoreduction index after resection, if there is no evidence of disease, it is CC 0. If the macroscopic disease is less than 0.25 centimeter, this is CC1. If 0.25 centimeter, 2.5 centimeter is CC2. And if the macroscopic lesion size is more than 2.5 centimeters, it's called CC3. So now I'll go to some trials which actually expressed the advantage of CRS HIPAC procedure. So this is a GIMSA trial. 60 is a prospective study, and 16 patients with gastric cancer with peritoneal mets or liver or lung mets, but resectable to CC0 were incorporated in this trial. They tried to see the overall survival. These patients were randomized to SA arm and GIMS arm. So systemic chemotherapy, folfoxiri alone, was given to the SA arm patients, and in the GIMS arm, multimodality therapy, gastrectomy, CRS HIPAC, and systemic chemo was given. So the median overall survival increased from 4.3 to 11.3 months. This is very important, and this is significant. And another thing is that no patients with systemic therapy arm survived beyond 12 months. You see the blue line is the systemic therapy and the red line is with the James arm. So no patient survived beyond 12 months, but with CRS HIPAC plus systemic therapy, patients survived longer. But all patients surviving beyond 12 months had CC0 and an initial PCI of less than 15. So the CC score and the PCI score is very important. And another thing is that there were no intraoperative mortalities in the James arm. Overall 90-day mortality in the surgical arm was 11%. This is another study done by Young et al. 68 patients with gastric cancer with peritoneal carcinomatosis underwent CRS and CRS HIPAC. It compared the efficacy of adding HIPAC with cytoreductive surgery. And here you see the median overall survival of CRS was 6.5, but with CRS HIPAC, it increased up to 11 months. This cytochip study, this is a French retrospective study in gastric cancer. Patient treated from 1989 to 2014, 352 CRS patients. So this study also looked at the CRS and addition of HIPAC with CRS. So in one arm, it is CRS patients, and at the other arm, it was CRS and HIPAC patients. And the median overall survival with CRS patients was 11.4 and CRS HIPAC was 18.6. So the median overall survival increased. So which patients do better in CRS HIPAC? So how do we select the patients? For this, to find out the patient selection criteria, Oliver Glahan et al. Conducted a study. This was a prospective clinical trial with 49 patients with gastric cancer with peritoneal carcinomatosis and made outcome measures for clinical pathologic factors that affect overall survival rates. Here, he showed that peritoneal carcinoma staging, that is 0, 1, 2, 3, and 4, and assessment of the completeness of cancer resection, that is CCR, according to primary stage of gastric peritoneal carcinomas. Here you see that if the primary stage of the disease was 1, then CCR 0 and CCR 1 was the highest. If peritoneal primary stage was 4, then CCR 2 was maximum number. That means if the patient comes early or our primary stage, then the complete cytoreduction is possible. This is the survival curve of this study. Here you see that if the patient with stage 1 and 2 peritoneal carcinomatosis, the median overall survival was 19 months. But in case of 3 or 4 peritoneal carcinomatosis, the median survival was 6.6 months. And the median survival with CC0 or 1 was 21.3 months, and CC2 was 6.1 months. That means complete cytoreduction is very important. At the same time, the stage of the disease. So in this study, preoperative ascites, resectable tumor, and CC0 or CC1 score came as significant predictive variance for median survival. Here are some other studies, Yunomura et al., Fujimoto et al., and this present study, they compare the median survival, and these were 13.9, 16.5, 11, 10.1, and 10.3. All these studies were done to see the impact of cytoreduction with IPO chemo. The IP chemo can be used at neoadjuvant setting as well. This is another study. This study assessed the safety and efficacy of the bidirectional chemotherapy, that is neoadjuvant intraperitoneal systemic chemotherapy, and to show the selection for cytoreductive surgery on peritoneal carcinomatosis from gastric cancer. So here you see the wash cytology before NIPS. 41 was negative, 24 positive. So peritoneal free cancer cells had been detected in 65, that is 82% patients before NIPS, and the positive cytology changed to negative in 63% patients after NIPS. Complete cytoreduction was done in 27 of 52 patients with negative cytology, but in only 4 of 27 patients with positive cytology. That is significant. So the survival of patients treated with NIPS. The patient received cytoreductive surgery survived significantly longer than that of no operation group. 2-year survival rates of no operation group and cytoreduction group were 20.4% and 40% respectively. Survival of the patient treated with NIPS in terms of completeness of cytoreduction, that is CC0 or CC1. Patient received CC0 survived significantly longer than those of CCRS1 group, and no survival difference between CCRS1 group and no operation group. The survival of the patients in terms of cytological status after NIPS. Patients with negative cytology after NIPS survive significantly longer than those with positive cytology. So CCR status and cytology after NIPS are the independent prognostic factors. The adverse effects were mild and there was no treatment-related deaths. You see, the only grade 4 complication was found in 1 patient. Pressurized interperitoneal aerosol chemotherapy, PIPAC. This is a drug delivery system, repeated application response evaluation possible, often 3 PIPAC every 6 weeks, may be combined with systemic therapy, which is called bidirectional. This is a diagrammatic representation how the PIPAC procedure has been done. PIPAC is performed under general anesthesia. PIPAC procedure is standardized among treatment centers. 2 trocars are placed, evaluation of PCI, 4 peritoneal biopsies. A nebulizer is connected to a high pressure injector here, and then a pressurized aerosol containing doxorubicin 1.5 milligram per meter square and cisplatin 7.5 milligram per meter square is applied through the nebulizer. The capnoperitoneum 12 millimeter mercury is maintained for 30 minutes. Then aerosol is evacuated, trocars are removed, and patients are discharged the next day. PIPAC is an aerosol chemotherapy, more uniform distribution and deeper peritoneal penetration when compared to liquid chemotherapy. PIPAC is safe and well tolerated, can be repeated many times, quality of life maintained or improved. Laparoscopic assessment of extent of peritoneal carcinomatosis and biopsies. PIPAC can safely be combined with systemic chemotherapy. If effective systemic therapy is anticipated, systemic therapy should be given 1 week after the PIPAC. This is a flow chart how PIPAC is given. PRGS1 in some patients with regression continue to CRS plus HIPAC. Heterogeneous populations, often retrospective and limited number of patients. Prospective trials and special randomized trials are needed. So far, 27 PIPAC trials, 13 in gastric cancer, and 2 small randomized. Here are some other studies with PIPAC. So it is a retrospective study. 24 patients with peritoneal metastasis from gastric cancer. Mean PCI was 16 plus minus 10. 18 of the 24 patients had signet ring gastric cancer. The outcome criteria was survival, adverse event, and histologic tumor response. Here they have shown that median survival was 15.4 months. Objective tumor response was observed in 12 of 24, that is 50% of patients. No vital tumor cells in 6, and major pathological responses in 6 patients and minor responses in 3 patients. Postoperative adverse events, postoperative adverse events, that is CTCAE more than 2, were observed in 9 patients, is 37.5%. 2 patients, ECOG 3 and 4, died in the hospital due to disease progression. This is a video laparoscopy and CT scan at the PIPAC showing multiple small bowel involvement. You see the white arrows, and in the CT scan, the red arrows. At PIPAC 4, video laparoscopy shows a complete macroscopic response. So here, no nodules in the mesentery or bowel. And at the CT scan as well. It is another trial. It is being done by the National University Hospital, where Dr. Bettina is working. This is a phase 1 study of pressurized intraperitoneal aerosol chemotherapy, PIPAC, with oxaliplatin and in combination with nivolumab in patients with peritoneal carcinomatosis. This is called a PIONEER trial. And this is a prospective single-arm phase 1 trial, 3+3 dose escalation and cohort expansion design. They're evaluating the safety and tolerability of PIPAC using oxaliplatin in patients with peritoneal carcinomatosis. And cohort 2 for combination treatment of PIPAC oxaliplatin at 90 milligram per meter square every 6 weeks for 2 doses with IV nivolumab 240 milligram on day 1 and day 15 every 4 weeks. We are waiting for the results. Now, neoadjuvant setting. Pressurized intraperitoneal aerosol chemotherapy, PIPAC, can be used as neoadjuvant setting as well before CRS HIPAC. And this study showed that this is a single institution tertiary center retrospective study, and PIPAC indication was not eligible for CRS HIPAC. That means those patients who are not eligible for CRS HIPAC, those are included for this study. And you see the downstaging, histological downstaging was 8 out of 9 patients, and radiological downstaging in 7 out of 9 patients. So neoadjuvant HIPAC can also be tried. And this is the survival curve. You see ovarian, colorectal, pseudomyxoma peritoneal do much better than gastric cancer. Many trials are ongoing, mostly are randomized. This is a GastroChip study. This is a D2 resection and hyperthermic intraperitoneal chemotherapy in locally advanced gastric carcinoma. It's a randomized multi-center phase 3 trial. And in one arm, HIPAC with oxaliplatin on patients with gastric cancer involving the serosa and or lymph node involvement and or with positive cytology at peritoneal washing. At the other arm, perioperative systemic chemotherapy and D1, D2 curative gastrectomy. This is another ongoing trial. This is a GastroPAC trial. This is an open label multi-center randomized phase 3 trial, 180 patients with gastric carcinoma or gastroesophageal junction malignancy and peritoneal metastasis. It has also got 2 arms, pre and post-operative chemotherapy plus gastrectomy and peritonectomy. And in another arm, pre and post-operative chemo with gastrectomy and peritonectomy with additional intraoperative HIPAC. This is another study, efficacy of HIPAC combined with systemic chemotherapy and CRS on peritoneal metastasis from gastric cancer. This is a phase 3 multi-center prospective randomized controlled clinical observation, HIPAC plus systemic chemotherapy plus CRS. They want to see the median PFS and OS and the adverse event. This estimated study completion date is August 1st, 2022. Class 05 trial. This is also a multi-center prospective 220 participant study, 1:1 randomized, and chemotherapy alone in one arm and D2 gastrectomy plus peritonectomy plus HIPAC, followed by systemic chemotherapy. This is another case control prospective study, and they wanted to compare the efficacy between and postoperative hyperthermic intraperitoneal chemotherapy with docetaxel combined oxaliplatin in patients with advanced gastric cancer. They have 3 arms. Group A, D1, D2 radical gastrectomy plus intraoperative HIPAC with docetaxel plus oxaliplatin. In Group B, D1, D2 radical gastrectomy plus postoperative HIPAC with docetaxel plus oxaliplatin. And in Group C, without HIPAC. So what is the take-home message? These novel therapies, PIPAC, CRS, HIPAC, and other IP are quite feasible with acceptable mortality and morbidity. So far, some encouraging results in terms of overall survival and progression-free survival. Intraperitoneal chemotherapy can safely combine with systemic therapy, but we need more phase 3 trial results, and randomized trials are ongoing. Thank you very much. So at the end, I want to show some pictures. This is the Asian peritoneal surface malignancy group, and this is the very first meeting in 2017 in Singapore. So you all are welcome to join who are interested in peritoneal surface malignancy. And thank you very much.
So thank you, Kallol. So for your very informative presentation. Now I would like to request our today's overseas expert, Dr. Bettina, to say our comments regarding these novel approaches. Later we'll discuss individually. So over to you, Dr. Bettina.
Okay. Yeah, thank you for the presentation. Very nicely done and summarized. As you alluded to before, my main interest is for peritoneal disease, predominantly for colorectal. So the gastric malignancy is slightly out of my usual expertise, but nevertheless, I'm familiar with the surgery for cytoreductive and HIPAC, as well as the PIPAC application. I think it is a relative novel approach, particularly the PIPAC. So PIPAC has not been around for very long. It is a procedure that was developed in Germany, and hence quite a number of the papers that have been just discussed in the presentation show data from German groups who have published quite extensively on this. And then one of the forerunners is a group which originates in Germany, with the chief of service being a gynae oncologist. So hence there's quite a bit of data available for ovarian cancers and the suitability for PIPAC for that. The other group that publishes extensively are more concerned with the gastrointestinal side of things. So that would be the stomach and the colorectal cancer groups. And then the other group that publishes extensively is the group in France, around Olivier Glehen, who was actually in the picture that was just shown for the malignancy course that we ran in Singapore a few years ago. So there are quite a number of experts in the field, and everybody brings their individual experience in. And as you quite rightly mentioned, we are still in desperate need of more advanced trials. So the pendulum swings backwards and forwards between rather extensive disease approaches as well as less extensive approaches. And I think if you look at the diametrically opposite procedures available on the spectrum, the PIPAC procedure is actually something that is relatively uninvasive in that sense, and does not, it is in essence a laparoscopic approach to the delivery of chemotherapy intra-abdominally. It does not require any surgical resection of any kind. It is just a modality of bringing the chemotherapy and delivering the chemotherapy into the abdominal cavity by a laparoscopic approach, and enabling the chemotherapy agents to be put in pressurized and aerosolized, which gives us better penetration of the tissues. Whereas the intraperitoneal chemotherapy delivery methods are usually via port placement, and then the chemotherapy is just infused into the abdominal cavity, very much like systemic chemotherapy, just that it runs into the abdominal cavity itself. And that is a treatment modality that is quite familiar to those of you who are doing gastric cancers as well as gynecological malignancies. It is not quite so commonly practiced in colorectal malignancy. So it's more common for the gastric as well as the gynecological malignancies, and has actually shown quite good results. And then lastly is the cytoreductive and HIPAC, which is a relative extensive surgery, requires quite long procedures with multiple resections of peritoneum as well as involved organs, requires training. And following the cytoreductive surgery. So cytoreductive surgery is basically the mainstay of the procedure, and then as an add-on is the application of the heated intraperitoneal chemotherapy. And depending on the actual underlying malignancy, the chemotherapy agents vary. So there's different chemotherapy agents that you choose depending on what malignancy you're treating. So gynecological uses, for instance, the platins and doxorubicin. Colorectal uses oxaliplatin or mitomycin, for instance. Gastric cancer would potentially use oxaliplatin as well. But gastric cancers are oftentimes quite advanced and aggressive, and cytoreductive surgery, HIPAC, is not quite as established because the results have not been quite as favorable as in other underlying diseases. So that is where we are. But this is really an evolving field, and the more people are getting involved in this and the more data becomes available, it will actually eventually probably tell us different parts of the story. So this is still something that is pretty much open for anyone interested in joining in. And it is a disease, as we all know, that is relatively common. So peritoneal disease is common in advanced malignancies. So I'm very happy to answer any targeted questions if I can. Please feel free to approach with anything that you might like to discuss.
So thank you, Bettina. We will discuss this issue individually. Let's share my screen. So there would be 4 points of discussion. Number 1, the route of administration, IP, IV, IP or intravenous therapy. And second, we will discuss regarding the HIPAC or PIPAC or cytoreductive surgery. So at first, we will discuss regarding this issue in advanced stomach cancer. If we think after radical surgery, if we think that there is a potential risk for developing intraperitoneal chemotherapy, so should we offer the patient intravenous chemotherapy or intraperitoneal chemotherapy? In this context, I want to see some studies that there are different randomized control study, number of patients, more than 2,000, also some RCT. They showed that significant increase in overall survival for patients for selective high risk group of patients, but at the cost of very toxicities. But this result not very evident in the long run in the 2 large randomized control studies. Both of them are Western studies that's published in 1994 and 1998. You can see that there is no difference between the intraperitoneal chemotherapy versus the intravenous chemotherapy. So there are 2 different results. In the randomized control trial, they have got some overall survival advantage. In the randomized, in a very designed randomized control trial in the Western people, there's not very evidence. So in this context, what is your suggestions in adjuvant setting? Should we go with intraperitoneal chemotherapy or intravenous chemotherapy as we are doing it? At first, Kallol.
Difficult questions for me to answer because really I'm not the expert on stomach cancers. The trials that you have just quoted, so stomach cancer is still a disease that is more prevalent in Asian countries than in Western countries. And therefore, I would probably encourage to look at data from Asian studies. So one beautiful trial on that is actually the Phoenix study that I think was presented earlier in the slides as well. And I think they've been using IP chemotherapy quite extensively in that trial and have shown good benefits of it, but not in the adjuvant setting. So this is pretty much a neoadjuvant therapy strategy in order to potentially enable surgical resection of the cancer, but not in the adjuvant setting. And I'm not entirely sure that there is any good evidence for IP chemotherapy in the adjuvant setting after resection. So even though I'm not an oncologist, I'm a surgeon and I'm a colorectal surgeon more than a gastric cancer surgeon, but I would probably tend to say the systemic chemotherapy would make more sense after resection, not only for the reason of the peritoneal treatment, but also because stomach cancer has often got nodal disease, so involved lymph nodes, and those ones you cannot treat with intraperitoneal chemotherapy. So that would actually require systemic therapy as well. So for those patients, I would actually probably think that the systemic chemotherapy would be the better option. I don't know whether we've got any oncologists here who would have a view on this.
Okay, let's see. Let's see. We have got ourselves Dr. Zaid Khan Bhai. He's from England. Right now practicing as a senior medical oncologist in UK. So Zaid Khan Bhai, can you hear me?
Yes, I can hear you. Can you hear me?
Yes. Yes, we want to hear your opinion regarding this adjuvant IP versus IV.
Okay, thank you very much. Just first to say it's a beautiful presentation from Dr. Kallol, and also really happy to hear Dr. Lesko's comments. It kind of makes sense to me as well. So first thing to say that I do both gastric cancer and colorectal cancer as a medical oncologist, okay? So looking at the trials, it's difficult to summarize everything and just quickly go, if you're asking on this particular question about adjuvant interperitoneal chemotherapy, then I don't think there is enough evidence to suggest that adjuvant chemotherapy should be in the form of intraperitoneal over systemic delivery. Number two, the best evidence, if you want to look at of intraperitoneal chemotherapy, I think we have to go back to the ovarian cancer clinical trials, because that's where probably the most evidence lies. And I don't think all these trials together has proven only a very modest benefit over systemic chemotherapy. And obviously, because this is a resource-intensive procedure to deliver intraperitoneal chemotherapy, and only very specialist centers can do that, it hasn't taken off as much as one would have hoped. Now, if you want to talk about ovarian cancer, colorectal cancer, then actually it will be a very different kind of discussions, where there is a little bit more evidence and more individual cancer center data available, probably to support. But obviously, that's not within the remit of today's discussion. But if it comes up in questions, we'll talk about it.
So your decision is IV. That is the standard practice right now we are doing, right?
Yes, I think that will be. So Shumon, if you look at all the trials, I think one particular difficulty is the number that you have in each of these trials. You have such a small numbers. It's very hard to apply that information to hundreds and thousands of patients. And as Dr. Lesko also suggested, that the Asian patients and Western population, their disease behavior, their treatment response is actually quite significantly different.
Thank you, Zaid Bhai. Kudjot Elahi sir has joined in this platform. Kudjot Elahi sir is the head of Department of Medical Oncology, Combined Medical Hospital. Kudjot Elahi sir, can you hear me?
Yes,
sir, can you hear
Dr.
me?
Suman, I can hear you.
I also want to hear your opinion.
Regarding this issue, I have very little idea and we have not practiced it. But I think IV approach will be better for this sort of patients. So far, my knowledge goes.
Thank you, sir. Professor Mofazul Hossain, sir, can you hear me? Mofazul, sir, can you hear me, please? Okay, so we probably have got the answer. So till date, there is no randomized evidence to practice intraperitoneal chemotherapy routinely. So as adjuvant, we should consider this intravenous chemotherapy as a routine standard of practice. So now come to our today's discussion in peritoneal metastasis. Is there any role of intraperitoneal chemotherapy? So as it is shown by Dr. Kallol, this is the Phoenix DC trial. This is the Japanese trial. They have tried this IV route versus IV plus combined with IP. Though they failed to produce any median overall survival difference, you could see that there is no statistical significance. But I am really focused in the 3 years overall survival. As you know, that the peritoneal metastasis, 3 years survival is a really very rare thing. And in this IP-IV combination, there is 21% overall survival. So what's your decision regarding this IP-IV combination therapy in peritoneal metastasis patient in respect of stomach cancer? Dr. Linsky.
Well, we've had the first author of the study involved in some of our meetings in Singapore, and they've obviously tried very hard in order to get this to work. So when you look at this, the plots indicate that there's a vast number of patients enrolled in this trial. So you can see the way that the curves run. There's definitely a lot more patients than some of the other studies that have been flagged up so far. And to my mind, Japan is an excellent platform to look at when you discuss gastric cancers, because they do have the patient volume in order to get any meaningful data out of any trial, really, as well as they're quite well organized, and you can be assured that the trials are well run. So when you look at the number of patients that they've enrolled for this is actually exceeding many of the other things that we've seen in some of the slides. And they have made a good effort in giving systemic plus the combination therapy of IP and systemic chemotherapy. So that is where your increased survival comes from, because these patients have benefited from the bidirectional approach. So it's not one over the other. So they're both getting systemic chemotherapy, and then the other group, the trial group, gets the IP chemotherapy on top of the IV chemotherapy, so the systemic. So they're getting the benefit of the systemic plus the peritoneal directed chemotherapy, which is the IP. So this is a bidirectional approach, which has shown to show some benefits of it. Now they have done an extension of this where they looked at resectability. I'm not quite sure whether you're planning to show that slide or whether you have it somewhere. But obviously the idea behind giving treatment for the patients is obviously to see whether you can get them into a resectable state. And as you know, for the gastric cancers, once you've got a patient who has got peritoneal disease, you will not primarily resect. So those are all the patients who are going off to have systemic plus IP chemotherapy treatment. And then you're looking at your response rate, and then you're actually looking at whether you get those patients into a state where they are potentially resectable, and then you're looking at overall survival from that point of view. So this is a sort of multi-pronged approach on this. And to be absolutely honest, far more complicated than colorectal cancer, as far as I'm concerned.
So thank you. Definitely we'll hear from you in our next session. That will be on colorectal session. So Dr. Zahid Khan, what's your opinion?
Apologies, sorry, the phone went off. I mean, this is very interesting. So you've got a higher number of patients on the interperitoneal and systemic treatment. The response rate, the median survivals, they're not too dissimilar, but then you have a big difference in the 3-year overall survival, which Dr. Linsky has tried to provide some insight into it. So one thing I would say, that if we just think about where I work in UK, this is a taxpayers funded NHS system where they look at the value for money, and they look at the clinical evidence that has significantly improved people's life. The NHS England, unfortunately, was not convinced for interperitoneal chemotherapy in gastric cancer. So they have never funded it. And actually, they even funded the HIPAC and CRS as well in gastric cancer. So my answer is that it looks interesting. And if you can select patient with low PCI index, and if you can feel that you can achieve, sorry, I'm going the wrong direction. It is something can be considered, but as I've said, that it is a resource intense procedure. So if the patients can afford it or the healthcare system can afford it, then it's a different question. But in UK, it is not funded. It is not available for our patients. So I'm afraid that is the bottom line, that I can't consider or offer this treatment.
Thank you, Zahid. Dr. F.M. Kamaluddin, sir, can you hear me? I know that you have some experience treating or follow up these sorts of patient getting this type of treatment. So what's your insight regarding this?
First of all, I want to congratulate Kallol because he brought up a novel technique, and we are happy that we don't have the technique in our country, but at least we have a trained person in our country. So as long as we have a trained person in our country, we are hopeful that very soon the technique will also come to our country. That is the first thing. So because Kallol is well trained on this, I know he has a good exposure on this. But regarding the experience, as you said, yes, the patient that we both followed. But you see, my experience is one is GI, but quite a few is on ovarian. And they are doing good when it was a mucinous type. And when the total CS with IP was given, and it has done a good survival benefit. And patient tolerated well. I mean, the amount of worriness that we had with the patient didn't happen so. So probably, I don't know, maybe we need to wait for more data, skill hand, proper selection of patients, and proper timing of the judicious use of this. I mean, non-judicious random use is dangerous. So I think very important is proper selection, skill, and also not only proper selection of the patient, also proper selection of the timing is also important. And for all histology probably is not equally benefited, what I know. But personally, I mean, I wish we have more experience in our country. And the patient that you are referring, I think it is 4 year plus. She is doing good.
So, Kudratullah sir, what's your opinion regarding these issues? IP plus IV.
Thank you very much. Because I have very little idea about this subject, so opinion is very difficult. I think I have one experience with intraperitoneal therapy in ovarian cancer. I have seen this patient coming from neighboring country, but regarding a gastric cancer, I have no experience, so I cannot comment it properly. Thank you very much.
So again, I want to come back to Dr. Zahid Khan because he has a mixed character. He born in Bangladesh and right now practice in England. So what would be the take-home message those who are participating here? So should we practice IP plus IV for these sorts of patients? If yes, who are those candidates?
I think I will be quite cautious about recommending this treatment for everybody. Because I said, number one, this is resource intensive and the affordability will be a very big question. But again, overall, I personally don't feel yet convinced that this is something that I can recommend for everybody. So I think my recommendation would be systemic treatment.
So thank you. Thank you.
What about Kallol's talk? I mean, I think we can get to hear from him.
Look, I am waiting for the CRS portion for him. Okay, Kallol, what's your opinion? Kallol, we can hear you.
Unmute yourself, Kallol.
Sorry. So regarding IP plus IV, I don't have much exposure because where I worked in NCC Singapore, this IP-IV protocol is not much practiced so far I have seen. But CRS HIPAC was done in a huge number so far I have seen. So rather I should talk on CRS HIPAC more.
Let's see. So CRS plus HIPAC, better than IP. It is already showed by Kallol. This is a Chinese study. They have randomized 2 groups, CRS plus HIPAC. All are peritoneal metastatic patients, the CC0 or CC1 group. And here you can see, it's a very interesting findings that the cytoreactive surgery, when it is synchronous presentation, cytoreactive surgery plus IP produce good result, but when it is metachronous, that the cytotoxic surgery resulted good rather than combined therapy. So I would like to request Kallol. So if a patient categorized in this group of patients, should you prescribe cytotoxic surgery along with IP, or what's your decision about this group of patients?
Okay. So actually, I have shown in one slide that the gastric cancer patients do worse than pseudomyxoperitoneal or ovarian or colorectal. That's the bottom line. So the gastric cancer randomized trials are still ongoing. So to draw any conclusion is difficult for me or for anybody else. So rather we should focus on the findings that are coming from some non-randomized trials or some observational studies. So whenever there is a synchronous mets in gastric cancer, it is easy to resect. And after resection, the main theme of the CRS HIPAC is you have to remove all the macroscopic disease. This is very important. If you keep some disease inside the abdomen, then your HIPAC won't work, because HIPAC has a limited penetration power. That is like 2.5 millimeter or something like that. So if there is a larger tissue in the peritoneal cavity, it won't work. Possibly in that's the reason. So whenever there is a synchronous mass and you do a good CRS and then you do HIPAC, then it is the overall survival has increased a lot. But if it is a metaconus mass, then possibly CRS HIPAC didn't do better.
So Kallol, so far I got from your discussion that you are in favor of this combination of therapy if you got a patient with this sorts of findings, right?
Yeah, CRS HIPAC.
Okay. So Dr. Liski, what's your opinion?
Well, it basically boils down to what we're trying to achieve here. So if you think obviously cancer treatment is a multimodal treatment. One thing alone is probably not going to cure the patient. So you need to tread very carefully to not mix up all the different modalities that you have available. So when we're looking at it from an oncological as well as a surgical point, you try and surgically remove the cancer if you can in order to achieve cure. It is very difficult to achieve cure by chemotherapy alone. There's only very few cancers that respond to chemotherapy without any surgical intervention and can consider to be cured. And all the therapies that we've been evaluating so far are not mutually exclusive. So oftentimes it's a multimodal treatment strategy to say, how are we going to treat and how are we going to serve this patient best? So we're looking at neoadjuvant treatment strategies, surgical therapies, as well as adjuvant strategies. And I think we have established that for certain cancers, such as gastric cancer and ovarian cancer, there seems to be some evidence to suggest that intraperitoneal chemotherapy in the neoadjuvant setting, meaning before resection, seems to be working. If it is resectable, it should be resected. During the resection part, the heated intraperitoneal chemotherapy plays a role for certain cancers. And again, it depends on the chemotherapy agents which are available. So not all chemotherapy agents work for all cancers. So it's very important to choose the appropriate chemotherapy agents. As well as once we have resected, we need to see that the patient gets some adjuvant treatment strategies. And that is most likely, most beneficial going to be systemic chemotherapy rather than anything else intraperitoneal. And then once we have looked at all of this, then there are those patients who might benefit from this rather novel treatment approach, which is the PIPAC, which again is more of a drug delivery platform rather than a treatment in itself, because it is just a chemotherapy delivery methodology. So I think there is a lot of issues that we need to think about here, and it's not which one is better, which therefore should we choose. It depends on the patient, it depends on the presentation of the patient, the stage, as well as what do we have available in the respective setting where we're working.
So thank you, Bettina. Dr. Sitabur Rahman sir, can you hear me, sir? Dr. Sitab sir, can you hear me?
Come on. Jahid, where's his hand sometime big up? So he might want to say something.
Sorry, I will come. I'll come to him, sir. So, Jahid bhai, what's your opinion?
So again, even if you just look at the median overall survival, which is increased from 7 to 11 months, and the force utilization for that, I wonder whether that makes sense. But what is really interesting, as you've said, the difference in the outcome in the synchronous and metachronous setting. The only way that I can possibly try to explain is that when you have synchronous presentation, you might not have any significant occult distant metastasis by then. So if you're resecting and if you're doing HIPAC, you are possibly getting a better disease control in that setting, whereas in the metachronous setting, even when you're treating the peritoneal metastasis, you are likely to have occult distance metastasis, which is likely to make this procedure fail more often than successful. That is my possible interpretation of this information. Again, coming back to the real world, again, NHS doesn't fund and hasn't approved or commissioned CRS and HIPAC in gastric cancer, is simply because the outcome hasn't been proven that great. I think we can probably have a more useful discussion if we ever discuss colorectal cancer setting in future. But as I've said, it's a no-go in NHS at the moment.
So we have, at the end of our discussions, we have discussed IP versus IV as adjuvant. We have discussed IP as a mode of treatment in peritoneal metastasis, cytoreductive surgery versus HIPAC. And there is also some options with PIPAC, but still not is in very evident. So let's take from ISMO guidelines. You can see that in the case of peritoneal metastasis, only small randomized trials show some benefit, but it is not even in the guidelines. So the cytoreductive surgery and HIPAC recommended outside, not recommended outside clinical research. So it is a topic of clinical research still. So in case of oligometastatic disease, in general, patients do not benefit from resection of disease, metastatic lesions. So don't push your patients a bit. Resection of primary in oligometastatic disease, regular trial showed no benefit. Feeling a bit enthusiasm might not get any benefit to our poor patients. And both gastrectomy and metastectomy is experimental. Let's see what's our Pan-Asian guidelines state. They are also in the same as the ISMO guidelines. You can practice this HIPAC plus all these novel techniques as a matter of research, but still then it is not in very guidelines. So that's all from me from today's discussion. So now I would like to request our very senior guest, Professor Firoz Kadir sir. So I think Dr. Shahriar Kallol, it will be better if you introduce Firoz Kadir sir to our audience. Shahriar Kallol. Kallol, you need to unmute yourself.
Sorry. So Professor Firoz Kadir sir is a veteran surgeon of our country. He was my direct teacher and trainer in Dhaka Medical College. So I'm very grateful to introduce him along with the other faculties. Professor Firoz Kadir sir, please a few words from you.
Let's check whether sir can hear us. Sir, can you hear me, sir? Okay, probably he is engaged. Otherwise,
Ahmed Said bhai. Ahmed Said bhai is there. Right?
So we have among ourselves a very senior surgical oncologist, Professor Ahmed Said sir. Said sir, can you hear me, sir?
Yes, I can hear.
So we need to hear from you regarding your inputs in these novel approaches, sir.
So I think I am audible now.
Yes, sir, you are audible.
I'm sorry that I participated or joined late, so I missed the deliberation from Kallol. I was very eager to listen it from the very beginning, but unfortunately I attended at the middle of the deliberation and discussions. So what I have seen that most of the experts from home and abroad, they are not much aware of this CRS plus HIPAC or surgery plus HIPAC in terms of gastric cancer management. Actually, we don't have any scope of practice in our country, but we have seen few patients coming from abroad having HIPAC management, but not with gastric cancer, for other malignancies, disseminated intra-abdominal malignancies. And few of them, in my opinion, I think they have shown some improvement. They have shown some improvement in quality of life in terms of survival. Um, we don't have any experience, but so far my knowledge goes, I think this is this should be reserved for those patients after having surgery and intravenous or systemic chemotherapy, those who have recurrences, those who are showing some sort of resistance to any further treatment, we can try HIPAC in those patients. Thank you very much.
Thank you, sir. Thank you for your very important inputs. We are at the end. So before ending, I just want to ask a very personal question to Dr. Liski. So what would be the expected cost if a patient wants to go for a CRS plus HIPAC in your institute in any way? What can be the expected cost?
I must honestly say I'm not entirely sure. But the cost is it comes together from various different parts of the treatment. So number one is the surgery itself. Then the intraperitoneal chemotherapy agent, which gets administered at the time of the surgery. I think there was the picture in the presentation that showed the pump. So this pump needs to be available. It is a pump that circulates the chemotherapy and warms it up. So that is an equipment that either can be on loan or can be bought by the institution who is going to deliver these procedures, but it's obviously one of those things that the hospital or the institution where you want to do this needs to have in order to do this. Anesthetic care, post-operative intensive care unit stay, high dependency unit stay, and stay on the ward. So if a HIPAC case goes very well, the patient stays for 10 to 14 days usually. However, if there are complications, and complications can occur after major surgeries, the patient stays a lot longer. And all of these costs need to be taken into consideration. So it is a rather extensive surgery, and probably akin to resection of recurrent tumors, plus the chemotherapy cost, plus the hospital stay cost. So it is not a cheap procedure, and I'm not entirely sure, depending on the healthcare setting, whether patients are insured or have to pay it out of pocket, can be quite debilitating costs. So it's not cheap.
So thank you, Bettina. Thank you for your precious time given us in this season, in these episodes. And as you know that your main focus of interest is colorectal. So we are going to start our colorectal session from next Sunday. So I hope you will join as a overseas guest, as a routine participants. I hope you will join over there.
I'm happy to come back. No problem.
So thank you, Bettina. So at the same time, I want to thank Dr. Shahriar Kallol for his brilliant presentation and for the presence of very distinguished guests, Professor Firoz Qadir sir, Mr. Rahman sir, Mufaddil Karim sir, Kudu Kelai sir, Selim Raja sir. So thank you very much. Now I'd like to request our scientific partner, Sanofi's representative, Dr. Shahriar Kobi, to say a few words. So you have only 2 minutes time, Dr. Shahriar.
Thank you very much, sir. Assalamu alaikum and a very good afternoon to you all. This is Dr. Shahriar Rahman. I'm working as a MSL manager in Sanofi. First of all, I would like to thanks Professor Dr. M.A. Hai sir and Dr. F.M. Kamaluddin sir for their honorable presence and making this program enriched. And I also like to thanks Dr. Hasan Shahriar Kallol for his wonderful presentation, and also our foreign faculty, Bettina Lakes, for her wonderful insights on the topic. And last but not the least, I would like to thanks Dr. Mustafa Aziz Shumon sir for his wonderful moderation of the event, ensuring smooth flow. And finally, Sanofi, I would like to convey my gratitude to Oncology Club for letting us participate in this excellent scientific program. And as a science-driven company, Sanofi is always happy to participate in these type of events, and we very much look forward to participate in coming events and extend our hand for the scientific section. So thank you very much, sir.
Thank you, Dr. Shahriar. And now I would like to hear a few words from our academic secretary, Dr. F.M. Kamaluddin, sir.
Thank you so much. I think I already talked on this issue. I mean, nothing much to say. First of all, it was a interesting topics. I think it was brainstorming for all the juniors, because maybe we don't have it, but we should know about it. That is the philosophy, that knowledge should not have any boundary. Maybe the technology today is not there, but we don't know. First leap take long time, but the second jump take very short time. So as I mentioned earlier, I'm happy that we have now 10%, just we need the technology. And as Professor Ahmed Said was telling, and Dr. Zahid was telling, may not be promising in gastric, but there is promise in ovarian and colorectal. So we must use where there is an opportunity on a selected patient. And personally, I really enjoyed the discussion, and I always love the way of discussion from Zahid, because he tries to bring up the issue in a very practical perspective, that the very rational, the objective of NHS for clinical and financial justification. And I think it is very important what Mustafa Aziz Shuman was trying to summarize, that we know many things, we hear many things, we see many trials, but we should not be tempted to jump into everything. We should really be cautious about thinking of some modality, and always think about the cost and benefit of something, and all, not only financial, also the treatment toxicity. Are we really offering something? Because the patients sometimes really push us for something, but it is us to take a judicious decision. And we can only take a judicious decision when we have enough knowledge about it. We look at that trial, we should look at the strength and weakness of the trial, not only look at the card that there is a separation. We should look, let's say Zahid was telling, such a small number of patients. So all these things for our juniors, I'm telling, today it is evidence-based era, but don't jump into all the evidence. Look at the strength and weakness of evidence and try to use it judiciously. And finally, great job, Kallol. Well done, Shuman. And thanks to Bettina and Zahid, all the participants. Thank you very much.
So thank you. Now it's time to hear from our chairperson, Professor M.A. Hai, sir. So, Professor M.A. Hai, sir, can you hear me, sir?
Yes, you can.
Yes, sir.
Thank you, Simon. I'm really very happy and really excited to hear from Hasan Shahriar Kallol. It very nicely describes some event which I learned just now. I had no idea before. So my days are old. I have learned something from Hasan Shahriar Kallol today, so he became my teacher from today. Whoever teaches something, I consider him as my teacher. Thank you, Kallol. I've learned from you HIPAC, CRS HIPAC, PIPAC, PRGS1, all these things. They're very new things, and I'm really happy and thankful to you. I'm also happy for the discussions taking place by our participants, also within the state, although she is a colorectal surgeon, so she has taken part in the discussion. Also, I'm happy that Ahmed Said joined us today, has given us a new dimension. Thank you all very much. We had a very nice afternoon. Hope to see you again next Sunday. Okay, goodbye.
So thank you, sir. That's all from today's program. I'd like to request that our next program would be on next Sunday at the same time, 3 to 4 p.m. time. And from next Sunday, we'll start a new site that will be on colorectal carcinoma. So I would like to request all of you to join in time. So till then, stay safe and let me say goodbye.